The strength of women's health is a reflection of world strength. So, on the occasion of World Women's Day on March 8th, we at Star Health have taken the initiative to raise awareness about women's health. This is Dr. Nikarika. I'd like to welcome our esteemed guest, Dr. Anusha Raj. She's a senior consultant in obstetrics and gynecology and has recently trained in laparoscopic surgery under Dr. PG Paul in Kochi. Thank you so much for joining us, Doctor.
Pleasure.
Would you like to say a few words before we start?
Now, this is like my home ground, and I'm privileged to stay here. And that too, I do have a lot of conflicting thoughts about celebrating Women's Day, because every day should be Women's Day. Cannot be one day where you're being, where you're being honored, because that itself says that there is gender inequality, because we don't make noise on Men's Day, isn't it?
That's right. All right. So we'll discuss a lot about women's health, the common issues, the myths, all of that. We'll debunk it, and we'll have a wonderful session ahead. So we'll start. Thank you. We'll start ahead with the theme for World Women's Day this year. It's Invest in Women and Accelerate Progress. So what would you like to tell about the theme?
It is an age-old theme. Like, in olden days, people say you make women study at home. The entire family is on the track. Okay, likewise, you invest in women. There are a lot of benefits in the society. So I think that is the brainchild of this, this year's theme. And again, everything points out to our 2030 goal. The United Nations 2030 goal is to achieve gender equality, combat gender inequality, against fighting against poverty, where that can actually raise women and child health. When women and child health, it comes up, that raises the backbone of that particular community or that particular society. So it is an apt and a much required theme for this year.
Yes, Doctor. What do you think are the common health challenges faced by women these days?
The common health challenges, yes. A woman starts facing a challenge from the time she attains menarche, because that is not only a bodily transformation, that is a mental, physical transformation, an emotional transformation, and a mental transformation. So from there, everything starts. So from there, we start to look at it. It is like the problems a girl faces during menarche, like how to handle it. Handling menarche is a task for the child and for the mother. From there starts nutritional anemia, then problems of bleeding and pain, and then problems of conceiving, and other problems in the female genital tract, and then the much dreaded cancer. These are the, rather than calling it the common problems, this is the array of problems a woman goes through from the day she attains menarche till the day she dies.
All right, doctor. My next question is, menstrual pain is very common among women these days. And could you tell us, when should a woman be concerned about menstrual pain? At what time they should go and meet a gynecologist to probe?
Yeah, that's a very, very important question, and I'm very glad to actually address that question. See, pain is something, it's a very subjective thing. What we are told at home, or what majority of them are told at home, periods, there will be pain. Bear with it, okay? That's what everybody says, and you're going to go through childbirth. But yes, you need to have some pain tolerance, but then you need to know when you should go to the doctor. See, now it is the era of a particular disease called endometriosis. See, endometriosis is not cancer, but it is something that will spread like a cancer, and it is an extremely painful condition. And one important or one vital sign of endometriosis is pain. And this pain, is associated with periods. So when somebody is complaining of progressive pain before or during and after periods, which we call as the triple dysmenorrhea, it's 3 times. So dysmenorrhea is pain. This is one alarming sign. So at that time, that is one right time to consult a doctor to rule out whether you have endometriosis. Endometriosis, in a nutshell, it is It is a condition where there is this inner lining of the uterus. It should be present in its place only. If it is present elsewhere, it is going to cause pain. So that is why when somebody is experiencing this kind of pain, progressive pain, where the need for painkillers are increasing with every cycle or increasing every year, that is one place or one alarming sign where you need to consult a doctor.
Or even pelvic inflammatory diseases cause a lot of.
They do cause a lot of things. Yes.
Shed some light, please.
Definitely. Now, pelvic inflammatory disease, this is, inflammation is not a process that happens only during periods. It is a process that happens always. So that is where we actually differentiate between this endometriosis and pelvic inflammatory disease and pain due to fibroids in the uterus and all. Now, in pelvic inflammatory disease, it is basically an infection. See, the female genital tract is open to the exterior. So very easily they catch up infection. If this infection is not treated properly, it moves up. It moves up to the uterus, it moves up to the fallopian tubes, to the ovaries and inside the abdomen. And this we call as pelvic inflammatory disease. And this will cause severe lower abdominal pain and back pain. Now, this can also go on to cause infertility. And like endometriosis also can cause infertility. That is not able to conceive. That is why these two needs to be addressed. And how do we know about pelvic inflammatory disease? Excessive vaginal discharge. Not only white discharge, it can be any kind of offensive discharge. Recurrent urinary tract infection. Or this constant lower abdominal pain, not the cramp, but the constant lower abdominal pain. These are all signs of pelvic inflammatory disease and they need to be addressed immediately. The target population will be reproductive age group, that is 15 to 45.
A very trending condition these days amongst adolescents is PCOS. Could you tell us the difference between what PCOD and PCOS is and how can it be managed?
Yeah, no, this is a very, very common diagnosis patient makes by themselves. They walk in telling that they have PCOS, PCOD and all. So what is this PCOS, PCOD? PCOS is polycystic ovarian syndrome. PCOD is polycystic ovarian disease. Now, how do we differentiate? Basically, these two are interrelated. Now, what we do is, in PCOD, now there is only problems with the reproductive, like changes with the hormones of the reproductive tract because of too much of follicles in the ovary. So what happens? The periods are irregular, they don't conceive, and they have issues with that. Excessive bleeding or no bleeding, like that. Now, in PCOS, there are certain other interrelated hormones which work along with the ovary. Most commonly, the male hormones. Females should have a limited amount of male hormone. Now, only then the entire system will function properly. Now, in PCOS, what happens? These excessive follicles, excessive small cysts that form in the ovary. What happens is these secrete more amount of male hormones. When more male hormones are secreted, what happens is external appearance. The patient looks, and the particular girl or the female, they have a lot of facial hair. They have thickening or darkening of the skin behind their neck. They put on a lot of weight, abdominal obesity, truncal obesity, loss of scalp hair, all that actually happens. Now this is, and then apart from this, they will also have some amount of insulin resistance. When they have insulin resistance, they become a pre-diabetic or a diabetic in a very early age. And it doesn't stop there. It also has other changes like some cardiac risk factors also increases as a result of obesity and insulin resistance. And finally, it doesn't even spare the uterus, causing uterine malignancy. Now, this is not to scare. Why? I will explain why I'm talking so much from here till malignancy when we talk about PCOS. Now, when all these happens, this array, when this sequelae happens, when there is a chance for the sequelae to happen, that is called polycystic ovarian syndrome. Okay, is the difference clear now?
Yes, doctor. My next question is, infertility is a rising concern. So can you tell us how can it be diagnosed and what's the management for it?
For infertility?
Yes.
Yeah. Now, okay, let us talk about infertility, and we will actually stress upon one important factor where we can actually fight against endometriosis, PID, infertility, and PCOS. Yeah. Okay. Now, what is infertility? Now we've changed from infertility to a term called subfertility. Like there is a decrease in the fertility of a particular couple or a particular patient or something like that. They are not called totally infertile. They are less than the general population. Now, first we need to know when we are actually going to coin the term as subfertility. That is, see, immediately when somebody is married, the dictum is they should get pregnant. Okay, that is the dictum of the society. But actually, now it has actually changed in a way that going to a fertility treatment has become a very common, it is like a common behavior in every household. You need to know when you are actually subfertile, when you actually have to go to a doctor. Now, on an average, if you see, in 1 year, there's something called frequent intercourse or frequent sexual activities, which is about 3 to 4 times a week, irrespective of whether the woman is ovulating or not. Unprotected frequent intercourse for a period of 1 year, 80% of the couple will conceive. Okay? And in the second year, 90% will conceive. So the remaining 10% who stay after 2 years, they come into the subfertility category who will require treatment. Apart from that, there are other known factors like the semen count is very less. There is some other metabolic complication for the man, or for the women, she has a endometriosis or any other complication, hormonal complication. She is a PCOS. She requires treatment. All those, they will need earlier treatment. But then this is how infertility should be diagnosed and should be managed.
All right, that was very insightful, doctor. My next question is, what are the common malignancies these days in reproductive women's health? And
Now,
what are the danger signs that they have to pick up and go to the doctor to?
Now again, I will take this opportunity to talk about preventive gynecology also. Now, the malignancies of the genital tract starts from the cervix, where women get cervical cancer. Cervical cancer it has a viral oncogenesis. That is, there is an organism which is high risk for causing cervical cancer. So that again takes us back to preventive gynecology, where they say to get vaccinated against the virus. That we call as the human papilloma virus, which should be human papilloma virus vaccine, HPV vaccine, which should be given to girls before the onset of sexual activity. Yeah. Now, considering the rural population and the urban population of India, the vaccination age for girls have started at 15 years. When somebody is taking a vaccine before the age of 15 or at the age of 15, 2 doses of vaccine is sufficient. When they are taking after 15 years, 3 doses of vaccine, like how we give a hepatitis vaccine, 0, 1 and 6 months, they need to take it. Now again, there comes a question whether those who have gotten married, should they take the vaccine or not? Anytime it is protective. Only thing is, you need to find out whether you're actively having HPV infection and then go ahead with taking the vaccine. Anytime you take the vaccine, it is protective. Okay, so that's about cervical cancer. Now then we move out to the uterus, which is uterine cancer. The most common cause for uterine cancer, apart from genetic predisposition like HNPCC or colon cancer, the most other risk factors are obesity and PCOS. If somebody is getting less than 4 periods a year, if somebody is suffering from recurrent episodes of abnormal excessive bleeding after a period of 90 days of amenorrhea, not having periods and all that is high risk for endometrial cancer. It says that there is unopposed estrogen activity which will cause endometrial cancer. And other metabolic risk factors, hypertension, diabetes, obesity, all these causes endometrial cancer. So again, we go into preventive community gynecology, where we will target about lifestyle changes and treating PCOS.
Okay.
Okay. And then we move to fallopian tube and ovaries. Fallopian tube cancers are very rare, but they are precursors for ovarian cancer. There again, when we talk about preventing ovarian cancer, once the family is completed, it is a good practice to get sterilization done, which will actually disconnect the conduit between the ovaries and the tubes and ovaries and the uterus, so that when the connectivity is not there, the spill from the fallopian tube is also not there. That is protective. Any salpingectomy or sterilization is protective of not having ovarian cancer. Ovarian cancer, strictly there are no screening tests, but these are certain preventive strategies that can help with not getting ovarian cancer.
All right. And could you tell us about antenatal care for the mother and what tests need to be done once they find out that they're pregnant?
Yeah, this is, this is very important. What we need to know is, first thing, it is extended physiology. that it is not a disease. But still, there are certain things that we need to do. We may, when we see patients in the antenatal clinic, you will have the mother, the mother-in-law, the grandmother-in-law, or the grandmother who keeps on telling that we didn't have all these tests in our day, back in our days. So, even for a scan, you need to get permission from the heads of the family, or you need to convince them. So for that, you need to stress on the importance of these scans. Earlier days, the infant mortality, the maternal mortalities were very, very high. These two are the health indices of a particular society. Now we rank number 2 in health, because we brought down maternal mortality and infant mortality to a level where we are up on the scale. Now here, in order to do that, we need to first find out whether the mother is high risk or low risk. If the mother is low risk, then her routine care will go on in the primary care. If the mother is high risk, when we diagnose it at the first point itself, we know what care to give her and what not to give her. And when the mother is carrying a baby, the health of the baby is equally important, which fortunately can be found out by scan and a lot of blood tests with the upcoming technologies. So basically, the most important scans, apart from the early pregnancy scan and the growth scan, the scan that is taken in the 3rd month, which we call as the first trimester scan or the NT scan, where we check for Down syndrome. Down syndrome is one preventable cause of mental retardation that happens, which can be fortunately identified when the baby is in utero. So in order to prevent that, this NT scan is a screening test that can be done. And you have another scan called the anomaly scan, which is done at 20 weeks, where you can find other parts of the baby, whether it is grown well or not, so that we can prevent a deformed baby from being born, or rather, you can actually prepare the parents to welcome a baby with defects or what needs to be done later. So this is basically the scans that need to be done. Apart from the routine blood tests like checking the hemoglobin, urine routine and all that, very, very important test that needs to be done is checking the blood sugar of the mother. Because India being the diabetic capital, and with a lot of family history of diabetes, even people who are lean, people who are very fit, people who have a proper lifestyle, pregnancy is a different story, because after 20 weeks, the placenta, the afterbirth, it secretes a hormone which actually blocks the function of insulin. So any woman is actually prone to become a diabetic when she is pregnant. So we need to check the blood sugars and keep the blood sugars on test. It has different values in different trimesters of pregnancy that can be handled in different trimesters in different treatment in different ways. Now, another important test is checking the thyroid. Now, again, this thyroid is one, everybody says, doctor, thyroid, how come in pregnancy I'm having thyroid? Should I take the tablet lifelong? What happens if I don't take? The value is normal, the lab value is normal and all. Again, the point I wanted to stress is pregnancy cutoffs are different. And the mother's thyroxine has a lot of value. It has a lot of impact on the baby's brain growth and baby's both physical and mental growth. So these two are the two tests that I wanted to stress upon during pregnancy.
Okay, doctor. Could you tell us about postpartum psychosis, postnatal care for the mother?
Yeah. Now, this is again very, very important, because mental health of the mother not only affects her, it affects the family, it affects the baby, it affects her future, her future lifestyle also. Now, this postpartum psychosis, yes, there are factors like previous psychiatric illnesses, like anxiety, depressive disorder, or bipolar disorder, or family history of schizophrenia, or chronic depression. These are all factors, that high risk factors for postpartum psychosis. Apart from that, if there is a unknown domestic violence that is happening for the mother in the term of both physical abuse or mental abuse or financial abuse, that also can cause postpartum psychosis. Now, there are two entities. One is called postpartum blues. The other is called postpartum psychosis. Postpartum blues, every 8 of 10 women undergo postpartum blues. Those are because of the mood swings that happen because of hormones during pregnancy and delivery. And that is self-limiting. That actually settles within a week. But this postpartum psychosis is very important. Every mother who delivers, or every attending birth attendant, or the family member should know the symptoms of postpartum psychosis. Estrangement from the baby, constant fear of dying, or fear of wanting to kill themselves, or wanting to harm the baby, or overprotecting the baby from others. These are all signs of signs of postpartum psychosis. If identified by the caretaker or the birth attendant or the person who's taking care of the pregnant women or a delivered women, that should be brought into attention. Again, postpartum psychosis is a medical emergency. We should not just brush it away, telling that ipoda deliver panirka, she will have a lot of swings, she'll have a lot of mood swings and all. It's not something that should be neglected. That is very, very important, and it needs to be checked.
Absolutely, doctor. Thank you for highlighting that. Could you tell us about the role of medical health insurance in women's health?
Yeah, when it comes to medical health insurance, majority of insurances, insurance is basically to cover something which we do not expect, like an accident or a sudden illness or anything. When it comes to women health, everything is planned. The first thing that arises is during pregnancy. Again, pregnancy and childbirth is a planned phenomenon where insurance has a very, very little role. Even if we have a little role, we have a lot of constraints to that. We only pay this much, like that. I think we need to, women need to be given that amount of financial independence to deal with their own pregnancy and to deal with their own childbirth, so that they don't, the burden is not on the family, where people choose. That's why they don't choose to go for a lot of blood tests, or they feel it's unnecessary. That is something that we need to think of. The other thing is about about the female genital tract illnesses, most commonly bleeding. People think that bleeding is normal. You bleed, you get pregnant, again you bleed, then bleeding stops. Okay, and you have a lot of insurance people, like they kind of say that we don't cover for some time, we don't cover this particular illness, this is not illness, how do you prove? A lot of factors are like that. I think we need to come to certain standards where we can accommodate these illnesses, so that will increase early diagnosis and preventive gynecology, and that will actually accelerate women's health, and that comes to fall in our theme of this year's women's health.
We at Star Health provide a special exclusive policy for women. It's called Star Women's Care Policy, where we offer prenatal and postnatal care. We cover their expenses, including surrogacy expense, newborn child expense since day one, and vaccination expenses as well, even in utero surgeries. So for more information, please click on to the description link in the box below. Thank you so much for watching this show. I hope it was very informative for all of you. Please subscribe to the Star Health channel for more interesting and interactive sessions.